Happy International Women's Day, and thank you for joining us for this conversation today, which, as you can see from the title, is going to be all about menopause and glycans. My name is Rina. I am currently studying biomedicine and working with GlycanAge, and I'm incredibly happy to have the opportunity to talk to our guests today. So without further ado, I will go ahead and invite them to join. Hello, and welcome.
Hello there.
Hi.
I will start with quick introductions of everyone here. So first of all, we have Dr. Louise Newson, who is a GP and a renowned menopause specialist, as well as the founder of the Newson Health Clinic and the Balance app. We have Professor Tim Spector, who is a professor of genetic epidemiology at King's College London and the scientific co-founder of the company called Zoe. And last but not least, we have our very own Professor Gordan Lauc, who is a professor of biochemistry and molecular biology at the University of Zagreb, as well as a chief scientific officer at GlycanAge. So before we begin, I will give a brief summary of what we will discuss in the following hour. So Dr. Newson, Professor Spector, and Professor Lauc, who we have here, have authored a recent study which focuses on the change in the glycome of women going through perimenopause and menopause. And so in the conversation today, we will discuss the findings and the implications of this study, but also talk about perimenopause and menopause in a broader sense, taking into consideration the currently available tools and diagnostic tools and treatments, as well as what we hope the future will bring in the field of perimenopause and menopause. So make sure if you have any questions to put them in the comments. We will come back to them towards the end of the interview, and all they will be answered in the comments during the interview. So I guess the natural place to start is to ask Dr. Newson to first of all define what perimenopause and menopause are.
Yeah, so thanks very much, and thanks for inviting me to this today. So the menopause, if we break down the word, it's just meno is the menstrual cycle, so women's periods, pause is stop. It's actually quite hard to make the diagnosis because it's a look back in time, retrospective diagnosis. So officially, a woman isn't menopausal until she's had a year since her last period. The perimenopause, peri just means around the time of. So this is a time when periods often start to change in nature or frequency, but menopausal symptoms occur. And the perimenopause and menopause occur because our hormone levels deplete. Our ovaries only have a finite number of eggs, and so when the eggs decline and reduce in number, the associated hormones reduce as well. So it is a natural process for women, but it isn't natural to be without our hormones. We're not designed to evolutionarily live for as long as we do without our hormones. But for some women, it's not natural. It can occur because their ovaries are damaged, for example, by drugs or radiotherapy, or women have their ovaries removed as well in an operation. So those women will have a menopause. The average age of the menopause, not that any woman's average, but the average age is 51 in the UK. But around 1 in 100 women have an early menopause. So these are women under the age of 40. Perimenopausal symptoms can start up to 10 years or so before the menopause. So that means most women in their 40s will either be perimenopausal or menopausal.
You are leading one of the world's largest menopause clinics, and could you reflect on what we currently have, what diagnostic tools we currently have for perimenopause and menopause?
Yeah, so if you look at the guidelines, it's looking at doing FSH blood test, which is a follicle stimulating hormone blood test, which is a hormone that our brains produce, and the levels increase if our estrogen level is low. However, in the perimenopause, our hormone levels don't just gradually decline, they're very haphazard. So there are some times that women have higher levels of estrogen than normal, and other times they have lower levels. And so the blood test can actually be quite falsely misleading. So if I did a blood test on someone who is perimenopausal, I might find that their FSH blood test is normal or even suppressed, but that's only in that snapshot at time. So actually in the clinic, if I'm seeing women, even young women, I tend not to do blood tests because they don't help. What is really important is looking at their symptoms, but the symptoms really vary. So some women just might get some muscle or joint pains, they might get headaches or worsening migraines, they might get low mood, feeling irritable, feeling more forgetful. And so it's very difficult to know whether these symptoms are related or not. A lot of women also don't have periods if they're on the contraceptive pill, or they have a Mirena coil, or if they've had a hysterectomy. So a lot of it is thinking, well, actually, it probably is hormonal. We often give HRT, and that will answer our question when we see how they respond to hormones.
I like that you made a comment about it's very difficult to recognize the symptoms, and possibly it's partly because there is so little research into perimenopause and menopause. So could you reflect on that a little bit?
Yeah, so people have been scared about HRT and hormones for 20 years or so, actually. And we know that, I mean, for me as a physician, I'm very interested in making people feel better. Of course I am, but I'm very interested in disease prevention. And we do know that when women are menopausal with their low hormones that last forever, whether they have symptoms or not, they have an increased risk of diseases such as heart disease, diabetes, osteoporosis, dementia, clinical depression, even types of cancer. And these are all inflammatory diseases. We know that estrogen responds to every single cell in our body, including our immune cells. And so we've known for a long time the dangers of low estrogen and this association with all these diseases. We have also known for a long time that women who take hormones have a reduction risk of all these diseases as well, because you're treating the underlying cause. But actually, we've been scared away from our own hormones because of a study that came out nearly 20 years ago. But actually it was misreported, it was misinterpreted, it wasn't set up well. We can go into it more details if we need to. But because of this, research in menopause has sadly been lacking because of this unfounded scare, but also, I hate to admit it, on International Women's Day, but because it's about women. So it's been neglected for two big reasons, which has been such a shame and very detrimental to the future health of women.
But the three of you are changing that, thankfully, with your study, and I think you've set us up very well. So, Professor Lauc, could you explain what the aim of the study was and quickly summarize the findings?
So, my lab focuses on a type of molecules called glycans, which are a kind of post-translational modification of proteins. So, analogy is maybe what epigenetic glycosylation is to proteins. And we study proteins in many different aspects, like proteins, and one of the things is aging. And we know that glycans change a lot with aging. We developed a test called GlycanAge test of aging. But interestingly, while men age more or less linearly, in women, this there is rapid acceleration of aging in around the menopause period. And it was very difficult to study because we didn't have a longitudinal cohort of women where from the same woman would have sampled through time. And fortunately, Tim has this fantastic cohort of twins. So we got from him approximately 2,000 women with samples taken 3 times across 15 to 20 years. And then we were able to show that in the period when women converted from a regular cycle to a menopause, there was much faster glycan aging than in other periods.
I can ask Professor Spector about the TwinUK cohort and what the benefit of using it for this study was.
Yeah, well, I should also say that I'm old enough to have done menopause clinics in the 1990s, probably before Louise was born.
No.
And when actually they would just really start getting going, and everyone was put on HRT at that point before they were scared. So there's been a sort of up and down. I've seen, several times in my career about popularity of HRT. And I do remember when I started, 50% of female doctors were on HRT at that particular time. So it is something that's been around, but as Louise says, really lacking in a lot of detailed research, lots of controversy, not much research. So, and most of us are basically given the standard test of try it for 3 months and see what happens, which is still good, practical, pragmatic advice. But it's great that we are doing some research, and the twins are perfect to do this because, you can look at the genetic effects as well as the environmental effects. And we do know that, just as everything else, timing of menopause has a strong genetic component to it. People tend to follow what happened to their mother or their sisters, older sisters. And so it's nice to have the twin model so you can look at the other identical twin and check whether the results were the same, or sometimes when one twin had an early menopause and the other one a late menopause, looking at those differences, you're matching for everything else except that particular event. And so that's been very useful for our studies. And we also, as Gordan said, we've managed to bank all these samples over 20 years, which is quite unique, really, to have this glorious database. And that allowed Gordan's lab to look at glycan aging in such great detail over time, because a lot of studies are done just as a snapshot, and we never really know whether it's cause or effect or which way around it is. But to have this amazing picture through sort of a couple of decades, I think really reinforces how important it is, and how glycans are really just showing how biological age changes during that time in a significant way, and in a way why women suddenly catch up men for all these other, men are, they start going downhill very fast in life and just keep going. Women are doing really well, and then suddenly have this over 10 years really catch them up. And I think that's really what this these magic new molecules and this test of biological age is doing.
No, exactly as you said. So there was we can see a change in glycans in this 10-year period. So Professor Lauc, could you just reiterate what these changes are and what they mean?
So we know that glycans attached to immunoglobulins, to antibodies, they regulate inflammation. So they're not only biomarkers, they're actually functional effectors which decide whether a specific antibody will promote inflammation or will it suppress inflammation. And inflammation is a process which is evolutionarily developed to help us fight invaders, the bacteria, viruses, and so on. But we have to remember that until 150 years ago, very few of us lived beyond the age of 35. So there is no evolutionary pressure to control this low-grade chronic inflammation in the long term. And as we are getting older, there is more and more inflammation. So actually inflammation is starting to become our enemy. So from our defender, it is becoming our enemy, and inflammation is underlying so many different chronic diseases of middle and old age. And glycans are here not only biomarkers, but functional effectors. So what we see in women in this perimenopause period, that glycans very quickly change from immunosuppressive glycans, so glycans which suppress inflammation, into glycans which actually promote inflammation. So we believe that this is not only a biomarker, this is actually a molecule which is causing damage because it's promoting inflammation.
And as you said, this inflammation increases as we age, but really this concept of inflammaging comes into play.
Yes, so there is entire hypothesis of aging which includes inflammation, or at least one aspect of aging is driven by inflammation, because inflammation is a process where you destroy infected tissue. So the cells of the immune system come in, they fight the enemy, there is a lot of damage, and then this damage is being repaired. But the low-grade chronic inflammation, which happens all around the body all the time, is consuming huge amount of energy, and in the same time is leaving these microscopic scars of damage which is being repaired, which is then promoting more inflammation, and it's actually a vicious circle which leads to aging. And this is particularly a problem in the modern society because of our unhealthy diet, unhealthy lifestyle. We are killing our microbiome with all the processed food and all the conservatives and so on. And then when on top of that, you put a hormone deficiency, which happens in the perimenopause period, this can really be tough for a person.
No, I'm glad you used the term hormone deficiency, because Dr. Newson, you put a lot of work into rebranding menopause as a hormone deficiency. So could you explain what this means really?
Yeah, absolutely. I think for too long we've thought about the menopause as something that's almost shameful, something that's been a taboo. But also, if you ask people what the menopause means, and we have done, for some television work I did a while ago, we stood in the street and said to people, what does the menopause mean to you? And they say flushes, sweats, irritable, shouty women. You know, women have been sort of just, there's lots of cartoon caricatures of menopausal women, but actually, I've already said the symptoms are far more than just hot flushes, but it is a hormone deficiency that affects us all. But the hormone deficiency lasts forever. So I would love to rebrand the menopause. I would love to give it a new medical term as a female hormone deficiency, so FDH. Because once you talk about deficiency, you start to think, well, what is it? What are we deficient in? And it's a hormonal deficiency. So it's not even just estrogen. Estrogen is very important, but actually testosterone for women is very important too. We produce about 4 times more testosterone than estrogen from our ovaries when we're younger. But we know the biological effects of estradiol are incredibly important. And as Gordan says, for activating our immune system, we have to have our immune system really well primed. And I've got an immunology degree as well, and I'm very interested in how our immune system, when it goes wrong, and as Gordan says, when it has this chronic low-grade inflammation, it's detrimental to our bodies. And we know all these inflammatory diseases, the ones I've already listed, so cardiovascular disease, type 2 diabetes, osteoporosis, clinical depression is thought to be an inflammatory disease. And we know that when estradiol levels are low or non-existent, we get this pro-inflammatory state. So we have to be thinking of the menopause as a long-term hormone deficiency, because we know most women last around 30 years being menopausal if they go through the menopause when they're 50. Well, I've already said 1 in 100 women are younger than that. So there's a huge chunk of time we haven't got their hormones. And as Tim quite rightly says, actually we're very healthy when we're young, and then it falls off a cliff. We know the risk of a cardiovascular disease, or even an MI, a myocardial infarction, a heart attack, increases by a factor of 5, because estrogen is very anti-inflammatory on our endothelium, our blood vessel lining. It helps regulate all these cells, but it also helps with nitrous oxide as well, which is very protective of our cardiovascular system. We know also that 1 in 2 women over the age of 50 develop osteoporosis. 1 in 3 have an osteoporotic hip fracture, far more common than men. Dementia is far more common in women than men, and this is because of the protective effects of estrogen that are lost with our menopause. So if we think about the hormone deficiency, it also encourages us to think about hormone replacement and what the benefits of HRT actually are for most of us.
No, we will come back a bit later to the treatment that's available today. But as you said, women, as we know, women live longer than men on average. But as you said, we develop more chronic diseases than men. So do the findings from this study give us an insight as to why?
I think they absolutely do. We've neglected basic pathophysiology, basic science with estrogen for 20 years because we've been scared away from it. Cancer research even tell us that it's a carcinogen. It can cause cancer. Well, of course it can't. Otherwise, every young woman would have cancer. We've got, you know, the data from the WHI, the Women's Health Initiative study that scared everyone away from HRT, is actually very reassuring, because recent data following women up for 20 years has shown that women who have had a hysterectomy and only have estrogen have about a 40% lower risk of developing breast cancer. Now that will blow people's mind, because most people think estrogen causes breast cancer. Of course it doesn't. It actually has been shown to be a treatment for breast cancer, but we know these anti-inflammatory properties. And so I've been working with Gordan just really for a while, thinking about how can we demonstrate these anti-inflammatory properties of estrogen and this pro-inflammatory state that happens. It's well documented. We've known for years about estradiol affecting the immune system. So this research is confirming what we know, actually, in a very exciting way, and hopefully the start for more research that's going to happen going forwards.
Yeah, obviously you've said the impact of estrogen and just sex hormones in general on the immune system. But Professor Lauc, is there a particular impact these sex hormones have on glycans?
We have done one very unique study on hormones, sex hormones and glycans, with collaborating with a group in the US who had both young women with a chemically induced menopause, and also men which had this chemical blockage of the sex hormone production. And we have seen that people, when you block them the hormones, either estrogen or testosterone, their IgG glycan changes rapidly and they age up to 10, 20 years in a couple of months if you stop the hormone production. If you restore the hormones, either estradiol or testosterone, this does not happen. So we had a randomized placebo-controlled study where women were given either the estrogen patch or the placebo patch. So only those who got estrogen, they were protected from this increased aging in the glycan way. And interestingly, men were protected from aging by testosterone, but only if the aromatase, so the enzyme which is converting testosterone to estrogen, was not blocked. So often people who are taking testosterone, they try to keep the testosterone level high by blocking the aromatase, because testosterone is naturally being converted to estrogen. And if you do it, yes, you do have a high testosterone, but your GlycanAge is increasing because you actually need estrogen. So both women and men, the IgG glycosylation of IgG is controlled by estrogen. We are currently doing a number of different studies to see what is the exact mechanism, so how estrogen does, which genes are involved and which proteins, but this is still ongoing.
What we do know so far, as Dr. Newson said, is that chronic diseases increase in this period of perimenopause and menopause. And so particularly for women who perhaps still are experiencing their periods, what would be the benefit for them of having an early perimenopause diagnosis?
Well, we see so many and speak to so many women who have a delay in their diagnosis, especially women who are young. So some studies have shown that it can take around 10 years for early menopause to be diagnosed. And certainly we see a lot of women who have not been diagnosed because they've been misdiagnosed with clinical depression, or migraines, or recurrent urinary tract infections, fibromyalgia. We're seeing a lot of women who are being told they've got long COVID, and actually their symptoms are they're due to perimenopause or menopause. We know it's related because when we replace their hormones, their symptoms all improve. And so actually we also know from studies that the earlier hormone replacement is given, the better the future health, because you're replacing this deficiency. Hormone replacement therapy is a bad term actually, because we're not replacing hormones, we're just topping up. We're just going back to a natural stage. We're trying to reach a physiological response. So for young women, they often need higher doses. Older women often need lower doses, but we're just trying to match what they should be having. But we do know that inflammation occurs very quickly. So if you look, for example, at bone metabolism, there's this balance of the osteoclasts and osteoblasts that break down bone and build bone. When we don't have estrogen on board, there's quite an accelerated deterioration in bone density. There's quite an acceleration in atherosclerosis, so the furring of the arteries, if you like, the increased risk of heart disease quite early on after the menopause. And there's some great work by Walter Rocker in America when women have had their ovaries removed when they're young, and he's looking at methylation and some of this accelerated aging, and it happens quite quickly, which is actually very concerning for us as women, but actually it shows the urgency almost for us to be able to make the diagnosis properly. We don't want women suffering, and we hear so many suffering of women who have having symptoms, but actually as a physician I really worry about their future health. And it's the same with diabetes. You know, we really want to pick people up with metabolic syndrome with pre-diabetes rather than waiting until they're full-blown diabetic, if you see what I mean.
No, absolutely. Thank you for mentioning HRT. That's probably the most obvious option when it comes to treating perimenopause and menopause. But Professor Spector, if I'm not mistaken, most of the twins and TwinUK cohort are women, and you've done decades of work investigating different components of their lifestyle. So are there any results from your work which would be particularly relevant for women experiencing perimenopause and menopause?
Well, we looked into the genetics of this, as I mentioned, and so the timing of the menopause, we were the first to show that it had a genetic component to it. And so many women are sort of unclear about when they might expect their menopause, because there's quite a big individual range. Although Louise has said the average is 51, it can be really anywhere, often, within about a 10-year span, and still be relatively normal depending on your genetics. And so that was the first thing we looked at menopause. But we've also more recently shown that in the twins that did the Predict nutritional study, that your metabolism changes quite markedly at the menopause. So with the company Zoe that I helped found we've actually been looking at how people respond differently to the same food. So just as everyone has different menopausal symptoms, how you respond to food is hugely variable as well. And so we showed that this tenfold difference between how people responded to an identical muffin meal in terms of their sugar, insulin, and fat responses. And what we showed in these Predict studies was that in that narrow window of 5 years, at the sort of peak time of the menopause, women's glucose responses, insulin responses shot up. So they were getting bigger peaks of glucose, but also peaks of fat 6 hours later in their bloodstream. So both of those are not good things to have regularly, because they are also triggers of inflammation. And so we talked about this sort of chronic inflammation, but actually what you eat is also another contributor to this, so that people who are unaware of it, having, say, high carb meals or lots of fatty meals, who are predisposed to it, who might have been fine before the menopause, as they hit the menopause, suddenly get this increased metabolic reaction that means they're getting multiple spikes during the day. They get increased hunger, more tiredness, and in the context of what we're talking about, more inflammation, and so will increase this aging cycle that we know is going on via the immune system. So I think that's been a real interesting insight, and that paper is going to come out in the next few days, but I thought I'd share it with you now. That so menopause is probably and nutrition, which also links to gut health and everything else in this holistic way, I think it is really important. So there are many other insights we've got from the twins, depending on how long we've got to chat about it. But certainly menopausal symptoms also tended to have a slight genetic component, but also half of it was rather random as well. So it's not totally predictable, the kind of symptoms people had.
No, I particularly liked your point that sometimes the foods that these women might have eaten for the majority of their life until menopause, they were absolutely fine with. And then once they actually started having these changes in hormones, which contributed to inflammation, at that point, these foods actually started to cause more damage than good.
That's right. I think it sort of explains why, women tend to gain more weight in that time of life than at any other period. And so often it's because they've been used to knowing how their bodies behave up to that point. They've known how to balance what to eat, and, relative to the other members of their family or their partners, and say, well, I always have a slightly smaller portion. This is my plate size. I have these meals. I can maintain my weight. Suddenly hit the menopause, it's not just feeling unwell or feeling hungrier. It just actually, the identical meal will have a different effect after the menopause. And this is really one of the nice things about the Zoe studies and, the Zoe test that you can do on yourself, is that suddenly you can realize how your body has changed in a bit the same way as the GlycanAge test, also look and see how your blood glucose and your blood fats have changed in that same way, and so you can readjust your diet and your meals. And this test, the Zoe kit, is now going to be available from April in the UK, I'm pleased to say. So, but I think it's all about also thinking about it, even if you don't do the kit, just realizing how different everyone is and how things might have changed, and what you believed was good for you in your late 30s may not be good for you 10 years later.
And I actually want to, I know this talk is mainly about prevention and early diagnosis, but I actually want to bring to attention women who might have already experienced menopause, but for whichever reason they haven't received HRT. Is it ever too late for them to change their lifestyle, for them to perhaps change their biological age, their microbiome, for them to go back in time a little bit and reduce the symptoms of chronic illness or menopause they're experiencing?
Well, I think what we've learned from these nutrition and microbiome studies has really reversed all my previous beliefs, because I'm a geneticist. I've used twins, so I always previously used to preach that genetics for everything, and basically all you could really do is blame your parents for everything, which is a strategy, but it doesn't get you that far. But what's really nice is that these differences in our responses to food, and that cause inflammation, are mainly driven by non-genetic factors, and so and that includes our gut microbiome. So both our food responses and our microbiome are mainly under non-genetic control, which means we can modify them. So I think it's a really positive message that you can change your gut microbes, and you can choose to eat foods that suit your body in this new state, and that means you can really regain a lot of control. And yes, you can come to grips with your biological age. It is possible to control your biological age if you really understand your body and how to go about it. So definitely.
Thank you. And Dr. Newson, regarding HRT, well, first of all, for women who might be in perimenopause, menopause, and also for women who have passed, who have been menopausal for a while, could you give us a bit of an overview about the benefits of HRT?
Yeah, absolutely. I've already said the main benefit is the earlier you take it. We know that women who start HRT within 10 years of their menopause, so usually it's women under the age of 60, have the most benefit, especially when you look at cardiovascular risk. But that doesn't mean it's not safe to have when you're older. And actually the HRT we prescribe now is very different, no disrespect to Tim, but the HRT that he prescribed in the 90s, or I actually prescribed in the 90s when I qualified as a doctor, because it used to be oral estrogen, and it was derived from horse's urine, so it was conjugated equine estrogens, lots of different estrogens together. Whereas now we prescribe this body identical, it's 17 beta estradiol, so it's just one type of estrogen, but it also goes through the skin as a patch, gel or spray, so therefore it's got no risk of clot or stroke. It gets absorbed straight through into the bloodstream, so it bypasses the liver. We also, quite differently to the older types of HRT, prescribe a natural progesterone, which is not synthetic, and the synthetic progestogens do have a very small risk of clot and stroke and heart disease as well, which isn't such a problem if you're giving it to young, fit people, but our risk of clot increases as we age. And so you wouldn't want to be giving the tablet older type HRT to someone in their 60s, 70s or 80. And in fact, the WHI study did show that there was an increased heart disease risk in these women given that type of HRT. However, we know that when estrogen is given through the skin, as I've said, there's no risk of clot. It can actually lower blood pressure as well. And it's so anti-inflammatory on the cardiovascular system that it's thought to actually be neutral or positive for cardiovascular risk. So it's great, actually. So it means that we can start women who are older on HRT. And we see that there are these metabolic changes that help and improve. We see that there's a lot of women who do put on weight during the perimenopause and menopause, and some of it will be lifestyle. When you're feeling rubbish and your joints are stiff and painful and you've got no energy and no motivation, of course you're not going to exercise and you probably won't eat the same way. But even people that don't change their lifestyle find they put on weight. But we know that, I've already said, we need estrogen in our body to work. The only way we can get estrogen when our ovaries aren't working is from fat cells, our adipocytes. They produce estrogen, but it's not a nice estrogen. It's a very toxic pro-inflammatory estrogen. And we know there's all sorts of chemicals that our fat cells produce as well, but it's the best our bodies can do. So people find that they do put on weight, but then they have a worsening of these metabolic processes, a worsening of their inflammation. So it's a double-edged sword. A lot of people find when they have the right dose and type of estrogen back, then actually their body weight it improves, so they lose weight because their body's not retaining every ounce of fat, and then often because they feel better, they're exercising more, they're more motivated, they're often drinking less alcohol, and they're looking at their diet more as well. What we don't know, which I'd love to know with some research with Tim hopefully in the future, is how our gut microbe changes when we have estrogen on board. Because we have estrogen receptors everywhere, we also have them in our gut. And I'm very convinced that our gut microbes will change beneficially when we've got estrogen on board, but no one's ever looked at that. And I think this is a really exciting area of medicine. You know, you only need to read Tim's Diet Myth to know how fascinating gut microbes are and how they've been neglected for so many years.
Thank you. And I will give you both a chance to talk about your companies and your apps as well, but I really want to make sure I mention, for any women who might be looking where to find the right information, who is trying to orient herself, Dr. Newson has put together an incredible amount of resources on her website, the Newson Health website.
Well, actually, sorry to interrupt, it's not the Newson Health website.
I'm sorry.
No, that's just for my clinic. So the website is balance-menopause.com. It used to be Menopause Doctor, and it's got over 2,500 different resources on it. Some we've started to translate. So there's videos, there's booklets, there's leaflets, there's all sorts of information, but also there's the free Balance app as well, which has a lot of information, but also an area where people can share their stories as well, which can help each other actually quite a lot.
No, incredible. And it's amazing you've made it all free and available. So it's an amazing place to start. So now going to Professor Lauc, who I've neglected for a little bit. So everything we've talked about so far about glycans might sound a bit abstract. It's all in the realm of research, but is there any way that people can already benefit from your research?
Yes, we are really trying to translate our research into something what people can use, because the same way Tim learned from the microbiome that we are all different and that we can change things, this is what I learned from the glycan, that we're all different, that there's no two identical individuals, and that we have to learn from ourselves. So we cannot just take universal advice and apply it to everybody. For example, recently we did a study on 1,000 people on 5 different diets, and each of the diet was beneficial for some people and not beneficial for others. So we have to have a way to monitor ourselves to see whether what we are doing is actually helping or harming us. And we have already launched this GlycanAge as a test of biological age, which is commercially available. So people can actually buy it, can test themselves, can track themselves through time and see what is happening. And for example, if we are talking about the perimenopause, we have frequently seen women with a good GlycanAge, being 20, 25 years younger than the chronological age, and then rapidly deteriorating in a matter of months for 10, 20, or even more years. And this is actually an early indicator of perimenopause. And this, we haven't done a lot of research here, but initial data suggest that this is one of the first symptoms which we can actually measure. Because, as I mentioned earlier, IgG glycan is regulated by estrogen. But the measuring estrogen at any given point in time is very non-informative because it can change from day to day, it can change within a day. While the IgG glycan composition, which is reflected in this GlycanAge, which is available, is an integrator of estrogen concentration in the last 4 to 6 weeks. So it's actually giving an average hormone concentration in the past week, so you can actually see when the change is starting, even before other symptoms start to develop, because symptoms are endpoints. When something is wrong at the molecular level, it takes time until we see it at the level of organ or organ systems. And here, we look at the molecular level. We see the first second step from hormone deficiency, and this is a change in IgG glycosylation. So in theory, people who are tracking themselves relatively regularly, every year, every 2 years, even when they are younger, if they see very rapid change in a GlycanAge, this suggests there is something going on. And if you're around the menopause age, and of course the menopause is one of the first suspects, but it can be other things. It can be, for example, we have seen now people who had severe COVID, they had their GlycanAge increase for up to a decade in a couple of weeks. But this can also happen with influenza. So acute viral infection can be also the cause for rapid change. So just a single test which tells you it gets worse doesn't mean you're entering perimenopause. It could be viral infection. But it's one thing which could be very informative. But of course, to translate this to formal diagnostics, it will take time. Diagnostic tests are regulated. It has to be validated, accredited, and so on. But at the moment, there is this lifestyle test called GlycanAge, which is measuring biological age, which then clinicians like Louise can interpret and give it a clinical meaning.
No, as always, as you said, there isn't this will not give you a definite diagnosis, but it does allow us to track our lifestyle. And as I understand, all of you have different experiences with GlycanAge. So I want to start with Professor Spector. And as far as I know, you've experimented a lot with your lifestyle, with writing your books and doing your research, and you've tested yourself quite frequently with GlycanAge. So what has been the benefit for you?
It definitely cheered me up as the main benefit, because I came out at about 16 years younger than my real age. So I love GlycanAge. I think it's marvelous. It made me a new man. And I've been tracking it for about the last, maybe nearly 10 years now. I don't know how quite long it is, but and it's been pretty constant over that time. And I also, over the last 10 years, my diet has got increasingly healthier as I've, tried to change for my own metabolism. I've done the Zoe tests, and I've eaten for my gut microbiome. And interestingly, 2 years ago, at the start of the pandemic, I started doing a little experiment on aging myself, taking a micro dose of metformin, which in rats and animals is an anti-aging that affects one of the sort of aging cancer pathways, and found that gave me an extra 3 years of life. So according to Gordon's test. So I'm playing with it constantly, and as Gordon says, when you get ill, you do get a slight blip, and it goes back again. But I think it's for long-term tracking of health, it's really great, and we're very excited because we're starting to look at it in combination with the Zoe tests and the predict ones to see how it fits into this overall plan of sort of inflammation. But I think it's looking very promising as one of these great tools. So yeah, I think we all need a little bit of feedback on how we're doing, pat on the back, and so yeah, it's been great for me.
It sounds great also that you are finding a way to use it in combination with Zoe as well, to track the improvement of your diet and microbiome as well. So Dr. Newson, you've also, as I've heard, received incredible results with your GlycanAge test. So are you open to share how you think this reflects on your lifestyle and the preventative measures you've taken with regards to perimenopause and menopause?
Yeah, absolutely. I'm not sure I believe my test because it came back as 30 years younger than I am. So, but you know, it's nice. But it's very interesting. My mother-in-law, who's in her 80s, did the test, and she came back as 38. And she had a hysterectomy when she was 36. She felt like she'd fallen off a cliff and was very scared how depressed she actually became. Luckily, her husband was a doctor and managed to find her some hormones, just some estrogen. So she started taking estrogen when she was 38. That's probably a coincidence that her number's the same, but she is very, very youthful. And so it's very interesting to see my age, but I would have loved to have seen it before I took HRT. So I was perimenopausal probably for far longer than I realised. I reached a crisis towards the end when my daughter was just despairing and made the diagnosis for me actually. But I was very struggling with my memory, my mood, my concentration. My migraines were terrible. I stopped doing yoga because my joints were so stiff. I couldn't be bothered to eat properly. I couldn't sleep well. We know that not sleeping obviously is very bad for aging as well. But I've always had a very healthy lifestyle. I don't smoke. I don't drink alcohol. I try and exercise when I feel well. I do a lot of yoga. I eat really healthily for my gut microbes. So I would have loved to have done the GlycanAge test, 5 and 10 years ago, because I know it would have worsened. And I could have looked at my lifestyle, which was pretty good, but then it would have given me another tool to think, what's gone wrong? What's changed? And if I'd also had the luxury of having the Balance app, so I could have monitored my symptoms every 3 months, then the two together would be really, really useful. We see a lot of women in the clinic who have come to see us. They do some bloods, and we find that their cholesterol is raised. We find that they're borderline hypertensive. Some of them have their HbA1c has increased a little as well. And so a lot of other doctors would have been giving them statins, giving them advice, lowering their blood pressure. So they're often on an antidepressant, a statin, an antihypertensive, often painkillers as well. Whereas actually, if we take a step back and think, oh, what's changed? Oh, well, they're telling me that they're feeling worse since their ovaries were removed, and give them HRT, then often they don't need all these medications. But having another biological test, I think, is really important, because so many women, and I'm afraid it is women, are not listened to, they're not believed about their symptoms. And so, but we also need sometimes a test to change our lifestyle as well. We've all seen people who, and I'm sure Tim has a lot in his clinical practice, who have had raised blood pressure. You tell them time and time again they need to reduce it, and then unfortunately they have a heart attack, and that's the time that they change their lifestyle. Well, we don't want to be waiting for an event, but the more biochemical information that we have that's very objective, then the more we can wake up and look at our lifestyle. And although obviously HRT is beneficial, we can't take HRT as women and expect everything to just slot into place. There's no point me eating McDonald's 3 times a week and drinking a bottle of wine before I go to bed and smoking 20 a day and doing no exercise. We have to look in combination. But often, poor women are often struggling to improve their lifestyle when they haven't got hormones. We wouldn't do that if someone had an underactive thyroid gland or type 1 diabetes and say, oh, sorry, don't take thyroxine or insulin, just look at modifying your lifestyle. So it's a joined up approach. And, I think I would love to monitor my patients before they start HRT, and we want to know how quickly can we reverse changing. This pro-inflammation, this inflammaging is really, really crucial to our future health. So I'd like to know, does it reverse quicker when we're younger, or if we start HRT within a certain length of time? Does it take longer if we start HRT to women in their 70s? There's so many questions that we don't know, and with combination with Zoe, for example, we can modify and improve people's diet in conjunction with their hormones and their whole lifestyle, because our healthcare system in the UK is in a crisis, but so is it globally. And I know Tim is as passionate as I am about reducing and preventing illness. It's about keeping us healthy rather than reducing illness. And if this is a test that we can use in a very sort of in a way it's a holistic way. It's not just a test that we'll take in isolation. We have to look at the bigger picture, which is what we should be doing in medicine. But sadly, medicine, often people work in silo and they think of one system. And this is a great tool to be able to take a step back, I feel.
No, I absolutely agree with everything you said, particularly the fact that it is all personalized, it is all individual. And we can't simply say that everyone will follow the same rules. With regards to anything in health, but as we can see now with menopause as well. But just coming back to GlycanAge for a moment, Professor Lauc, you are the person who's been taking this test for the longest, but you're also on the complete other end of the spectrum with regards to your biological age. So could you tell us a bit about your experience?
Yeah, so contrary to Tim and Louise, I'm 25 plus years older than my chronological age. Which is a little bit horrifying, especially since I know how much of a disease risk is associated with a higher GlycanAge. Since GlycanAge is not a diagnostic test, we are not making these claims, but there is a lot of research showing that this is actually predicting heart attack, stroke, and some other diseases. So yeah, that's not good. So I'm one of the typical of examples of how everybody is different and how we have to test on ourselves what actually works or not. Because the first thing when I learned that my GlycanAge is horrible, I tried to sweat it out. Meaning I was hiking for 4 or 5 hours a day in the mountains every day for months. And I lost a lot of kilos. I was much more fit, but my GlycanAge didn't improve much. So many people who have a bad GlycanAge, they were actually overtraining. So one thing which I learned, okay, I don't have to train too much. I do have to exercise, of course, a bit, but not killing myself in the gym. So what I learned about me, it's a diet and it's a stress. And these two things I cannot really control well. So I eat too much, especially desserts and such things. So and I live. My life is too much filled with stress, too much work. So I'm hoping that we will discover a magic pill. So we are doing a large metformin trial, we are doing a rapamycin trial, we are doing many different trials, hoping that we'll find a pill which will help me to continue eating and just taking a magic pill to, to improve my GlycanAge. So I'm the worst patient. I'm hopeless, but at least I see that when I'm losing weight, my GlycanAge goes down. When I go on holidays, my GlycanAge goes down. Which things get mad, my GlycanAge goes up. When I gain weight, my GlycanAge goes up. So at least I have, it's another thing which I said I will not go over 80. So when I approach 80, then I do something and go a little bit down. And then when I stop trying, I go up again. But it's an important feedback. You know, it's an information telling me that if I'm actually trying and doing something, it works.
Well,
And
you're very honest, Gordan. I don't think anyone else in a company ever says that. So I think it's a great.
The best thing is that you've got insight, Gordan.
Yeah, I cannot cheat because I'm measuring it and I'm getting these numbers over and over again, and it looks. So it's one day we'll have a magic pill for people like me.
Let's hope so.
And I'm really happy you mentioned stress, because I guess a lot of people might think they're having a healthy lifestyle, they're eating the right things, they're exercising, but stress is something we often overlook. So yeah, I'm very glad you mentioned that. Stress
is extremely potent driver of many diseases because stress response is the ultimate warning signal which evolved as a way to survive when somebody wants to eat you. So because through evolution, the biggest danger is of being eaten. Somebody wants to catch you and eat you. And when we sound an alarm, there is a danger, somebody wants to eat you, you shut down the immune system, you shut down the reproductive system, you shut down the digestive system and put all the energy in a sensory system, in a motoric system, and you just want to survive the next few minutes because it's few minutes that your life depends on. The problem is that in modern society, we are activating this type of a response because we are late for work, there's too much traffic, our boss is horrible, we have an exam or whatever. And then we are activating these horrible metabolic responses, which are completely messing up with our metabolism because of reasons which are not real life-threatening. And the fear and the stress and anxiety, these are horrible emotions which have very strong effects on many things, including the GlycanAge.
Looks like we've lost all of our guests, so let's try to invite everyone again.
We got disconnected somehow.
Yeah, there was an issue, and all of our listeners disappeared as well. So I'm trying to get everyone back in.
So maybe we can leave it. We were talking for 1 hour. That's
yes,
long
and
enough. Maybe you can we can make just a question. Maybe get questions by email and maybe respond to some of them. That may be a good idea.
Of course. I think most of the questions were already answered anyways in the comments.
Okay, so thank you very much for organizing this.
And thank you for joining.
So you're doing it great.
Thank you.
For everybody listening, Rina is just an undergraduate student. She's fantastic. So thank you very much for doing that.
And thank you for acknowledging me.
Okay. And thank you everybody for being with us for an hour.
Thank you.
So,
bye-bye.
Bye.